Thank you so much for inviting me. It is an honor to be here. For someone who don't know about our center, Yonsei Cancer Center is in Seoul, and our center has 12 X-ray units, including CyberKnife and intrabeam MR lineup. Carbon ion will be set up within the next 2 years. These are my disclosures. I had patent for deep learning based segmentation, and I also had a research interest in these fields. The purpose of this session is going to present the framework to evaluate the patients with spine metastasis. I also initially asked to prepare in the context of 3 specific scenarios, but ultimately this concept can be applied to all of the patients with spine metastasis. I'm going to go through spine SBRT indication by a risk-benefit ratio. Actually, it is difficult to divide into 2 sides, but if you understand these factors comprehensively, it is way better to communicate with the patient and reach the decision-making together. And there are several validated tools that help to assess its risk quantitatively. So in considering how to manage this patient-led to best framework, I've seen which was published by Memorial Sloan Kettering Group, which is so-called NOMS framework. And I strongly suggest to see this lecture by Redmond if someone is interested in case-based discussions. This framework looks at 4 specific factors: neurologic, oncologic, mechanical, and systemic. And we're going to go through each of it in turn. So to start with neurologic factors, when cancer metastasis to the spine or epidural space compresses the spinal cord, it is a devastating medical emergency that, if untreated, causes almost all affected patients to become paraplegic. And radiotherapy is the mainstay of treatment for most patients. However, randomized trials shown that for selected patients, the combination of separation surgery followed by radiation is superior for preservation of ambulation to radiation alone. And there are really 2 things we look at for neurologic standpoint. The first is the extent of epidural disease, and most commonly used system is Bilski grading system, which goes from grade 1, which patient has epidural involvement but no actual spinal cord compression, grade 2, which has spinal cord compression but there is still remaining CSF, and finally grade 3, which is spinal cord compression but no CSF fluid at all. And epidural extent itself really made great impact on local control. There were dramatically higher local recurrence in tumors with epidural involvement. The second thing we want to look at in evaluating all of our patients, if there is actual neurologic function, the scale most commonly utilized is Asia impairment scale. It goes from grade A, which patient has absolutely no neurologic function, down to E, which is patient who is entirely neurologically intact. The second thing we always look at is mechanical instability. It is the loss of spinal integrity because of a neoplastic process, which causes movement-related pain and progressive deformity. Precise assessment of spinal instability is always challenging and even more demanding for multidisciplinary discussions with neurosurgeons. For this reason, to facilitate communication and appropriate referrals between physicians, the scale most commonly utilized for this was developed so-called spinal instability and neoplastic disease score, briefly SIN scores. SIN score greater than 12 is considered frankly unstable. I don't think we radiation oncologists should memorize all of these factors, but we really do need to ask for our patients with spine metastasis to characterize pain. Is your pain constant or is it mechanical? If you move, it hurts. Patients who have mechanical pain are not going to benefit from radiation therapy alone, so they really need stabilization interventions. So this is just a case example that a woman had complained pain exacerbated by movement, shown lytic kyphotic lesion in C-spine, whose SIN score can be calculated 15, and you can communicate with a neurosurgeon for surgical intervention with their language. So in summary, the presence of neurologic deficit or high-grade spinal cord compression and higher SIN score These factors are always you must assess first to decide when the patient needs surgical consultation before spine SBRT. And understanding the current spinal cord tolerance data from available published reports of human data specific to image-guided hypofractionated SBRT is important to discuss the risk following radiation therapy with patients with spine metastasis. There are two recent papers worth referring to the practice. First paper by David Palma and their colleagues summarized dose-constrained use in ongoing clinical trials of SABRE and Dmax values, for example, Dmax values of spinal cord 14, actually CCOFAC 14 grains, single fraction 20 grain, 3 fraction 30 grain, and 5 fractions were mostly utilized. And as most people already know, there was also considerable variation with respect to how the spinal cord is delineated, and this variation has persisted. For example, the dose to cord plus radial margin, and thicker sac are dramatically different. And the dose gradient in SBRT plan, 1 millimeter of space is about 2.5 gray. So if you're looking at doses to cord and doses to cord plus 2 millimeter margin, they can be 5 gray off. And this is the first case of spine SBRT treated with MR-guided linear aspirated LINAC at our hospital last month. A spinal cord was crystal clearly visible in each session and during treatment, and then it allowed us to recontour and adopt plans which could further reduce cord dose. And second paper is high-tech report by Chagall. In this report, data-driven modeling and protocol-driven dose limits were also recommended, and dose volume was displayed by whether Dmax referred to thecar sac or spinal cord. And especially in re-irradiation SBRT, the author recommended the following based on available data, and also a table of maximum dose limits for 1 to 5 fractions for a range of prior radiation exposure are suggested. And of course, these suggestions can help guide practice, but there may be some clinical situation in which to exceed these recommendations. To learn more about spinal cord tolerance for re-irradiation, I suggest you see these lectures by Gaia. And now let's switch the gear towards the effectiveness and efficiency of SBRT. This is fundamentally linked to questions whether spine SBRT is more effective than conventional external beam radiation. Astro initially published guidelines for palliative radiotherapy in bone metastasis in 2011, and they updated 5 years later. There were 8 key questions in the paper, and one of them was about highly conformal radiation therapy such as SBRT. However, guidelines stated that there was insufficient data to support routine practice. Nevertheless, experts were shorter with the ideas that SBRT could be a solution to these following challenging situations. The practice pattern were moving in the direction of adherence to the guideline. For example, single fraction has become popular. However, at the same time, the use of spine SBRT has exploded in the last decade, despite lack of high-level evidence. And after update guideline, there were several prospective randomized trials which address these issues. Some of them are published, and one is presented in Astro. And first was study from Heidelberg. They compared 24 gray single fraction SBRT with 30 gray and 10 fraction. The results show that there is no difference in pain response at 3 months, which was their primary endpoint, but 6 months response was better in SBRT arm, even with faster improvement. And RTOG 0631 and multinational trials from Canada and Australia are the pivotal trials that recently presented or published. NRG RTOG 0631 trial compares 16 or 18 gray in single fraction with 8 gray in single fractions. However, there were no significant improvement in pain response at 3 months in SBRT arm, which was study primary endpoint. And I think we have to wait until the final publications. On the other hand, CCTG SC24 TROG 1706 randomized trial shows significant improvement in complete pain response at 3 months in SBRT arm. And those they tested was 24 gray in 2 fractions. And importantly, there was no difference in vertebral compression fractures between 2 arms. And this was the first phase 3 randomized trial to show dose escalation with modern radiation improve pain outcomes for patients with spine metastasis. And I hope this table clears up what I showed, and results of recent randomized trials are compared, and they use slightly different primary endpoint. Only TROG trial used complete pain response at 3 months as primary endpoint. And trial, if you see the inclusion and exclusion criteria, the third trial from Utrecht included non-spine metastasis as well as spine metastasis. And TROG trial included painful spine metastasis within 2 consecutive spinal segments, or 2 or 1, and excluded patient with highly radiosensitive tumor and sin score more than 12 and presence of neurologic deficit, and all that I have spoken of earlier. And RQG 0631 tried to exclude a patient with high-grade epidural high density grade tumor. And again, CSTG TROG trial was the only trial which is considered as positive and practice changing. And furthermore, SBRT had a durable effect at the 6 months final, also in final follow-up assessment. So based on recently published study, we can now say spine SBRT can be considered when this TROG criteria is met, and patient has life expectancy longer than 3 months. And I of course knew that Tata Memorial Hospital is one of the best hospitals in the world, but let's just remember that we aren't all treating in the same way in the world. And there were several interesting papers that I want to point it out, and one by our hospitals. And these papers show that treatment outcome can be differed significantly by the institutional experience. And these findings was given us a lot to think about. And oligometastatic disease is the topic that the previous speaker have covered, so I don't want to go in details, but spine SBRT is also very common in oligometastatic trials. And regarding oligometastasis, I just want to add one comment, that because we don't have validated biomarkers to diagnose the oligometastasis, we are entirely dependent on imaging examinations, and have used up to 5 definitions for granted in the practice. However, recent expert consensus has reached the view that the possibility to safely deliver curative SBRT determines the maximum number. And I want to show my ongoing project result that oligometastasis concept is not the dichotomy of view, but a spectrum of disease, which can vary by histology, and the concept can be expanded as new, very good drug has developed. And left side graph is stage 4 colorectal cancer with lung metastasis. And right side graph is stage 4 melanoma treated with immune checkpoint inhibitors. And the interesting part is overall survival in both sides decrease in proportion to the number of the metastases. Next, radiation sensitivity is also another important consideration when deciding spine SBRT. However, in my opinion, except lymphoma, seminoma, myeloma, just histology itself should not be the only X factor to decide whether to go SBRT or not. And thanks to recent studies about radiosensitivity index and genomic adjusted radiation dose, we now know that every patient is different and responds differently to radiations. Now, recently, we have shown that tumors with ATM mutation with or without BRCA mutations exhibited exceptionally great tumor response and local tumor control even after palliative radiations. And considering that in real practice, NGS panel screening of biopsied tumor tissue has become common, I personally use larger PTV with conventional fractionation radiation instead of SBRT in these patients. And there was an interesting poll by Radiation Nation that what regimen was most commonly used in patients who are not receiving spine SBRT. And 8 gray single fraction and 20 gray 5 fractions were the dominant regimens they answered. And I think no differently about myself, and this is my personal practice patterns of bone metastasis. And in spine metastasis, SBRT, I prefer 24 gray in 2 fractions, and sometimes 30 gray in 3 fractions. And plus, even in palliative radiation, not receiving SBRT, I preferred VMAT, because in Korea, VMAT is not really quite cheap, expensive than 3D CRT. And I think based on this trial, VMAT is beneficial for patients, even in terms of quality of life. And in summary, main concerns are usually core compression and spinal instability risk, and several other factors when deciding spine SBRT. And this is the summary, and this is take-home message. Again, these are the take-home message. The last two message is not I covered in this sessions, but something subject that we have to focus on in the futures. And I wish to express my sincerest thanks to Dr. Pathak for having me, and I hope we could get together and talk face-to-face in the futures. Thank you.